Because one of the core psychological construct that stands up in addiction cycle is the shame and the guilt. What's wrong with me? And after a while, that chatter in the brain becomes, maybe it is true that I'm broken, I'm damaged, I'm less than, right? And that becomes an identification of one's whole sense. And when you start telling them the science that cravings are not just in your mind, there's a biological underpinning of it.
Welcome to Power Up Recovery with Nutrition. It is time to make nutrition part of the conversation. I'm your host, Christina Veselak, and I'm so glad you're here. Did you know that it's our brain's job to allow us to cope with stress gracefully? But to do that, it needs to be fed optimally. Have you ever wondered why so many committed people relapse or maybe even die? Why so many people on psychotropic medication still feel lousy and still have cravings? What if the missing piece is food, the right food? What if the right nutrients like amino acids or even eating protein every 4 hours could actually balance your brain chemistry and your mood without medication and support lasting recovery? In this podcast, we explore the powerful connection between feeding your brain well, mental health, relapse, and recovery from addiction. We will share insights from experts, inspiring recovery stories, and practical strategies you can use today. Whether you're in recovery, a healthcare professional, or someone passionate about emotional well being, this show is for you. Let's dive in and discover how fueling your body and brain with the right food, the right amino acids, and other key nutrients can fuel your transformation today. Welcome. Hi, everyone. Welcome to the next episode of Power Up Recovery with Nutrition, where we talk with people who have their own success stories, professionals in the field, scientists doing cutting edge research in nutritional psychiatry. And today we have the pleasure and privilege of having a conversation with a integrative doctor who runs a treatment program that integrates everything that we know and love. Welcome, Dr. Latif.
No, very glad to be here. Thank you, Christina.
Dr. Umar Latif is a triple board certified psychiatrist in general psychiatry, geriatric psychiatry, and addiction medicine, a distinguished fellow of the American Psychiatric Association, an associate clinical professor at Texas A&M College of Medicine. He brings over 2 decades of experience to his private practice. He works with adults and seniors seeking personalized, thoughtful care beyond short-term symptom relief. Dr. Latif also writes a free newsletter on psychiatry and mental health, Psychiatry 3.0, which I'm going to start reading. And at the Nueces Clinic and Enterhealth, Dr. Latif provides care through Psychiatry 3.0, a modern evidence-informed model integrating root cause evaluation, don't we love it, genetic testing, functional psychiatry, interventional treatments like PMS, and psychotherapy. He also serves as Chief Medical Officer at Enterhealth, a dual diagnosis treatment center. Welcome.
No, thank you, Christina.
Can you start by just sharing with us how you moved from conventional medicine into functional psychiatry?
It's fascinating. Looking back, the dots connect so nicely. I never would have fathomed that I would be in this space. Over the last 15 years, my main treatment area has been for active duty service members and veterans and first responders in dual diagnosis. So, developing, co-funding national programs, scaling them, developing best practices. And so there was an awareness that what is evidence-based treatment versus evidence-informed treatment, there's a gap in that. A randomized clinical trial that is considered the gold standard already is going to have 5 years outdated medical information for us that we really cannot deploy to the care of our patients. And I wear a couple of hats in training, so board certified in addiction psychiatry as well as geriatric psychiatry. And in both fields, there was a keen sense that, playing Russian roulette with just one more Zoloft or Prozac is really not state of the art science. Our brain is much more complicated than that. And quite frankly, we all know, open secret in psychiatry, that the monoamine neurotransmitter hypothesis has been debunked for quite some time, and yet we hold on to it. So I had the opportunity to come on board at Enterhealth, which its clinical co-founder, Dr. Urschel, 17, 18 years ago, he introduced a model that was quite different than what was at that point considered standard of care, which was our traditional 12-step model, right? No one was talking about addiction is a brain illness. No, right? And so it would perpetuate the moral imperative of just don't drink or this, that, and the other. So Dr. Urschel started deploying evidence-informed, cutting-edge treatment at Enterhealth, bringing together finally, the science and the biology way before anyone was talking about medication-assisted treatment. Enterhealth was helping in that. So when I came on board as a chief medical officer, I was already coming into a system that was forward-thinking, and the leadership at Enterhealth maintained that curiosity, right? Is there a better way? Is there a better way that we can continue to make an impact demonstrated by outcomes for our patients? Dave Niffen Jr., the CEO at Enterhealth, he introduced me to functional psychiatry. He said, take a look at this podcast. It was between, I think, Mark Hyman and Dr. Greenblatt. And he said, tell me, what do you think about this, right? And it sparked my curiosity because none of this was actually new. It just had stopped being taught in our medical schools.
That's right. That's right.
So
research goes back to the 1950s,
yeah,
and nobody knows this.
Yes, yes. And so, one of the things that when I teach medical students is just this kind of there's a PowerPoint slide in my deck that shows over the last 10 to 15 years, about 83% of funding at a federal level in medicine has been for drugs and devices. So no one is going to fund micronutrient deficiency, zinc, copper ratios, any of those.
No. We actually, I and a couple of colleagues went to SAMHSA, I don't know, maybe 10 years ago, 10, 12 years ago, and literally asked for funding around reactive hypoglycemia and amino acid therapy. And we were bluntly told that there was no money available for nutritional research. It was all going to medication.
So now imagine a cohort of well-meaning physicians who are medical students who raise their hand for a higher calling, but this is the extent of their training. So this is all they know, right?
That's right.
And so I think we're in a very exciting time where we're bringing in interdisciplinary and interdisciplinary kind of knowledge, and all at with the focus of how can we improve not just lifespan, but health span. Let's shift, we all use the word quality of life, but what does that look like for the patient? Have we actually sat down and asked them that? Yeah.
That's a great question.
Yeah. So I think that's where, so in pursuit of that, so then I'm currently finishing a year-long fellowship with Dr. Greenblatt, Psychiatry Redefined, so that then I can kind of incorporate all of that knowledge. And again, one of the things that I want to emphasize is it's not either or. It isn't that we're forgetting about the role, very important role of medication, very important role of traditional evidence-based medicine, but we're just saying that it's just not enough, right? What do we need to and that hence kind of this model of Psychiatry 3.0 that, mirrors the model of Medicine 3.0.
Well, The language, I've been doing this for 30 years now and showing up at addiction conferences and speaking and exhibiting. And so I've refined my language over the years. And the language I finally landed on is, let's teach people how to feed the brain the nutrients it requires to function optimally.
Yeah, beautiful.
Yeah, this research has actually been in for decades. We've known this for decades. Not new research, but it's never, ever been part of the conversation. And yet it's so basic. If the brain is an organ, it needs nutrients to function. It is actually a physical organ made up of things, right? Actual physical things. And if these things we have to get in our diet, yes, the brain makes some of these things, but it makes them out of things that we have to get from our diet. And if we're not getting that in our diet, the brain literally cannot do its job.
Yeah, absolutely. Right. Some of the questions for the audience when you were at IMMH, and I think that's a conference that should almost be required attendance by practitioners. You
Shouldn't it,
know,
though? There's
it
so much amazing cutting
yeah,
edge information there.
yeah, yeah. And you learn, your brain like literally expands with people who are passionate in their field. And, one of the things in circles like this, I always ask, on whose behalf do you occupy this seat? Right.
Beautiful. Mm-hmm.
And if we forget that all of us who are in some form or the other involved in healthcare, who are we in service for our patients, right? And at some point, our knowledge set becomes restrictive and we stop learning from our patients who are telling us very important things, right?
Mm-hmm.
So I think there's a role where the way I describe it is traditional psychiatry 1.0 was conversation led, right? It was rooted in psychoanalytic, classical talk therapy. Let's uncover the unconscious through insight, introspection, long form therapy. And then Psychiatry 2.0, that has been kind of the main model of psychiatry over the last, couple of decades, is
That's right.
biologically driven, right? And within that biological sphere, we've looked at the era of neurotransmitters. Let's look at DSM categories, medication management. And then we've advanced things like interventional tools like ECT, transcranial magnetic stimulation. But the emphasis again has been on the disease model. Let's
That's right.
manage and control symptoms rather than the wellness model, right? So the way I look at Psychiatry 3.0 is truly zooming out, kind of a whole person paradigm. So we're integrating the best of neuroscience and psychotherapy, but we're reintroducing root cause functioning, right?
Yes.
And we're
Yes.
reintroducing lifestyle medicine and integrative medicine. So you truly have a comprehensive, evidence-informed approach. Because what I'm seeing is that we're doing some amazing stuff in lifestyle medicine here, some amazing stuff in functional medicine, micronutrient deficiencies, advanced genomics here. We're doing some really good complementary medicine stuff, but we have to bring it all together because all of it is happening to the patient at the same time.
Well, we have to bring it all together because it is happening all to the patient at the same time, impacting the whole entire body.
Yeah.
But we also have to bring it into mental health and addiction recovery in a very robust way. In my advanced course, I have a 2-level certification program. Level 1 is your basic nutrients, amino acids, and food. Level 2, we apply all the tenets of functional nutrition to mental health and psychiatry. And I first started getting these MDs who'd gone through IFM and these highly trained functional nutritionists. And I was intimidated. I was thinking, you guys know so much more than I do, except that nobody had ever taught them how to apply what they knew to addiction. Addiction scared them. Mental health scared them. And so what I was able to do was to take their knowledge and show them how to apply it with a few additions
Yeah.
to mental health and addiction. And this is the cutting edge.
Yeah. It's the application of that, right? And one of the things that I'm probably going to have a blog up on this is that you're implementing the through line of we start with foundations, right?
Mm-hmm.
Let's look at root cause analysis. Is this micronutrient deficiency? Is this a amino acid depletion or lack of absorption and stuff, right? And then, so we stabilize the terrain, right? So before supplements the lab, we have to start with the fundamentals. What's your food quality, right? Is it depleted of micronutrients or not? How's your hydration, electrolytes, circadian rhythm? Absolutely, right?
Okay.
And in addiction, unstable foundations are going to blunt every intervention, including nutrition, right? So if the foundation isn't steady, even the best amino acid or medication won't land, right?
Right.
Then we pull it through into functioning, right? So upstream, I'm looking at this, I'm identifying, and now what system is getting impacted? Is the gut-brain axis in line? Are we having chronic inflammation where we're not having absorption? What about cofactors for micronutrients or hormonal or metabolic stress, right? So we're not just naming the diagnosis, we're asking what system is truly disrupted,
Mm.
And the irony is that DSM, right, the gold standard, there's a root in the second or third paragraph of every diagnosis is rule out any functional impairment based on medical causes. And we just threw that out. We just threw that out, right? So really looking at functioning, but then formulating a treatment plan that we're following through with, right? And one of the challenges that when I talk to colleagues is about functional medicine is that the reality is that there are some less than good faith actors out there, right? And that's just a reality, right? It's a new field. It's not regulated. It shouldn't be regulated, but it should have some guardrails on it, right? So having a $1,800 fancy lab test and then another, $800 of supplements by itself, if you're not placing it into understanding what homeostatic functions are there, and then you're not just throwing everything in a blender. Let's look at one system, stabilize it for about 6 to 8 weeks to 12 weeks, retest, realign, reset, and then you continue following through. So your approach is actually pulling that knowledge base into the application. And that's what we need more of, right? Because otherwise that knowledge is not helping our patients.
That's right. And I see it, doctor, as empowering our clients and our patients to take care of their mental health as well as their physical health for the rest of their lives.
Yeah.
They're going to forget my name. They're probably going to forget your name, right? But if we can teach them to think in terms of context and these foundations themselves, and of course, some people are going to be more capable and interested than others, but most people are fascinated. When I tell my clients this, when I show up at street fairs and talk to the ordinary person about this, or an addiction conference and talk to a little peer coach, right? Their eyes widen and they say, I've never heard this before. This makes so much sense. And I can start applying it in my life today. And they're so excited and they're so grateful.
You're so absolutely bringing up, highlighting an important thing is a sense of bringing our patients a sense of hope and agency back again, right?
Agency, yep.
Because one of the core psychological constructs that stands up in addiction cycle is the shame and the guilt.
That's right.
What's wrong with me? And after a while, that chatter in the brain becomes, maybe it is true that I'm broken, I'm damaged, I'm less than, right? And that becomes an identification of one's whole sense. And when you start telling them the science that cravings are not just in your mind, there's a biological underpinning of it. There was this lecture at IMMH, which I think you were there that day, where the the natural biome
Mm-hmm.
in the earth and the soil, how it's connected with our gut microbiome, and it sends signals upstream. You know,
Yeah, it does.
5 years ago, I would have said, well, that's a little woo-woo, right? I mean,
Right.
what's going on here? And yet it is hard evidence-based science, right?
Yes.
And so there's often a biochemical, metabolic, and often nutritional determinant, right, for cravings. And once we start addressing that, identifying that, right, give a name to what's wrong, so then they can feel empowered that this is an internal locus of control. I have some path forward in my recovery.
That's right.
Yeah.
That's right. I remember, I don't know, almost 25 years ago. And I think this one interaction with this one patient is why I'm doing what I'm doing today.
Mm-hmm.
I was working at as a relapse prevention counselor. I did 10-day outpatient IV amino acid detox program. And this lovely woman walks in carrying her IV pole with her, starts to cry and says, I don't know why I'm here. I'm one of these people who the big book says is constitutionally incapable of sobriety. She says, I'm going to go through this program and I'm going to get drunk again. And that's the end of it. So her story was that this was her third treatment program. She had managed to string together, and people who know me know this story, but it's a wonderful story. She had managed to string together 2 months of
Yeah.
sobriety, white knuckling it. She was so proud of herself. She went to a Wayne Dyer motivational lecture,
Yeah.
recommitted to sobriety with every cell in her body, and was drunk within 2 hours of leaving that seminar.
Yeah.
And she said, the craving just came out of the blue. See, can't trust myself. It's hopeless.
Yeah.
I said, cravings never come out of the blue. Let's look back over your day. And it turned out that she had not eaten anything for 18 hours.
Yeah.
And so I explained to her the mechanism. She'd had a good breakfast,
Yeah.
but that was at 7:30 in the morning. She got out of the seminar at 10 o'clock at night. She had not eaten a single thing all day. And I explained to her how when blood sugar drops, adrenaline kicks in, sets off a craving, removes access to recovery skills. And so when she left that seminar, she was a sitting duck to get drunk. And when she heard that, she said, that's what, whenever I've had a slip and a relapse, I haven't eaten all day. You mean? And I said, yeah, I do. And that was the last treatment program this woman ever had to go to.
Yeah. The irony is, and Dr. Greenblatt talks about it, is Bill Wilson, right? The right father of 12-step, right? That shortly before his death, he was asked what is one thing he would like to be remembered the most for at the history books. And it wasn't the creation of Alcoholics Anonymous, but it was the Nicene study, the vitamin B3 therapy.
Exactly. I mean, he wanted to be known for nutrition. And nobody knows this.
Nobody knows this. And it is fundamental on how he suffered from vitamin B3 deficiency. His cohort of people who are struggling with recovery, he started giving them vitamin B3 therapy, and there was a significant improvement, right?
Significant improvement of psychosis and cravings and depression.
Yeah. This group has been promptly and radically relieved of severe and long-standing emotional deficiencies, right? So we need to kind of bring these things that have been sitting on some dusty bookshelves, back into service to our patients.
So could you run us through how you actually do this at Enterhealth?
Yeah. So it's a continuum program, and that's one of the things that you can't throw everything in a Vitamix blender and think it's going to be palatable, right? When it
Right,
comes out,
right.
you have to really do a comprehensive program. And
Personalized medicine.
right. But personalized medicine, not just what medicine is saying, but in an integrative manner, right? Let's
Right.
look at and we're learning too now that certain, and we've known this, right? For example, thiamine and folate deficiency. That's why in a detox protocol, we give intramuscular nutrition and nutrients that are depleted so that we don't have patients going to Wernicke's, Korsakoff,
That's right.
syndrome. So we know there's a link between micronutrient deficiencies and certain categories of substances. So the Enterhealth program works with a residential component in the beginning where patients stay uh, anywhere from 30 to 60 to 90 days. And if they need a evidence-based medical detox, they receive that, CWA-assisted protocols or Suboxone induction. So we can stabilize the acute medical crisis. And then we do some advanced testing. So we'll do some psychopharmacokinetic genetic testing to see if we do choose certain medications, what are applicable, what are more amenable to, bioavailability to the brain. And then we do some more than standard, what we call today a comprehensive blood test panel. We've added certain other things to that are markers for inflammation, markers for micronutrient deficiencies. We're seeing a lot of imbalance between zinc and copper.
I was about to ask about zinc and copper and pyroluria.
Yep, we're seeing a lot of that. And then we also are, depending on what their clinical makeup is getting some gut testing. So for example, Genova's Nutraval test. So we're looking at that. It gives us kind of a really good comprehensive initial panel. But then we're also having a PhD psychologist do a neuropsychological testing. We're individualizing with the therapist. Trauma and addiction go hand in hand. So
They do.
best in class treatment, EMDR, evidence based. Our therapists are trained in that. So we individualize who needs that or not. And then
Excuse me just one moment. Is that where you also identify, because the other huge relapse triggers are ADHD, undiagnosed or untreated ADHD, and TBI?
yes. Yes. So that's where we're saying, let's get the full neuropsychological battery. And then our neuropsychologists work very closely with that. So we're prompting them on, this is our clinical query. This is what we want you to focus on because we're seeing alcoholism move with age. So our geriatric patients are coming, especially female patients in geriatric age with heightened levels of alcoholism. But then we're doing something really interesting. And when we're talking about the integrative model, we're also looking at interventional science here. So unlike traditional transcranial magnetic stimulation, we're using an advanced model of TMS called MERT. And what MERT is that we have our patients, once they're clinically stabilized and they're off of a detox, because we don't want them on benzodiazepines, it'll give a wrong EEG reading. We get a resting intrinsic alpha brainwave profile. And what we're seeing is that addiction has an impact on it, right? So just a quick kind of refresher. So delta and beta are deep wave and light sleep. And then alpha is if I have my eyes closed, I'm just relaxed in a Zen state. Think of it as the idling, resting brainwave that is dominant, rest and restoration. And then, you've got your beta waves, which are the executive functioning heightened. And we're individualizing truly with precision medicine. We started from root cause. Let's look at their gut microbiome. Let's look at microdeficiency all the way to now. We're looking at EEG, alpha waves, And then we're mapping off of that on that patient, their individualized treatment protocol for TMS. So,
So TMS as opposed to, excuse me, as opposed to like neurofeedback?
so we are actually doing neurofeedback too. We're
Okay.
doing neurofeedback, but it's all deployed very intentionally. So
Sure.
there's certain treatments that we're doing at the residential level because in an acute detox, neurofeedback may or may not be as effective for that patient, even though there's some really, really fascinating studies about acupuncture and detox. We know that. Right?
Yes, we know that.
So, but once those patients have stabilized their system, we collaborate with Dr. Taylor, who's an emergency room board certified and functional medicine trained physician also. So she consults with us. She individualizes the medical part of it while our team is working on the psychiatric part. And now you've got a comprehensive treatment program that they continue to step down on an outpatient basis. And that's where the neurofeedback is then continued while they're in IOP. And then they get retested. They get retested on these systems. Okay, have we stabilized the inflammation or not? Or have we repleted the micronutrient deficiencies? Now let's go to the second system and the third system and so on.
Sounds very well thought out, comprehensive, and
Team.
organized. Organized. Yeah.
And
So
then
what
we're seeing some good outcomes then.
I bet you are seeing good outcomes. What are you doing in terms of educating people around, the role of food in their recovery?
So we have nutritionists. So yes, so every patient who is in our functional program gets a nutritionist evaluation. But, and this is really cool, we actually have a legitimate chef at Enterhealth. And so that patient's menu and treatment during that course will start becoming individualized based on that nutrition. So we've got educational classes, individualized nutritionists. Then we're doing the NutriVal testing, and that's where the individual and group treatment comes in.
How about cooking classes?
So we're not there yet. And that's one of the things in 2026. We're actually looking at, we were just planning out 2026, and cooking classes is part of that curriculum enhancement. It's fascinating. I have a colleague, we both did our fellowship in geriatric psychiatry 20 years ago at UT Southwestern. And I'm doing now 20 years later functional medicine. She's actually, as a psychiatrist, getting training out of Harvard for a medicinal approach, medical approach for cooking and training for patients. That's her passion. So we said, we would love to have you come over. It just
Goes hand in hand, doesn't
yeah,
it?
just
Well,
integrate.
the cooking thing is a particular beef of mine.
Tell me more.
I think because, and we think of this in terms of your lower socioeconomic client base, but it's actually true for your higher socioeconomic clients as well, is that many people in today's world simply have never learned how to cook, how to feed themselves appropriately, and nobody has ever learned that what and when you eat matters to your mental health and addiction recovery. But
Yeah.
even if you teach somebody that it matters, if you're not teaching them how to cook for themselves, they are likely to default back to their pre-treatment way of feeding themselves. And I'm
Yeah.
not talking about your eating disorder clients. I'm
Yeah.
talking about everybody.
Yeah. I think that's, I haven't actually thought about it this intentionally, but what it's profound in how simple and core it is, right?
Yeah.
Right. So it's because
Why we don't think about it.
that's why we don't think about it, right? Because just the very act of mindfulness eating, mindfulness meal prep, being aware, right? Uh, where the field is going is in GLP-1s, right? Let's cut the signaling and stuff. And GLP-1s have a role. They have a role, but not the primary drivers, right? I mean, we're seeing some fascinating signaling and research, where there's actually now trials in addiction space for GLP-1s, not only to reduce cravings for substances, but also for process addiction, right?
Mhm.
But to your point, again, you're bringing this full circle. You could be on a really good GLP-1 medication. Those systems are contained, but something as simple as meal prep and you're reverting back, I can see all that hard work just going backwards.
It all goes backwards. And not everybody can stay on these medications forever for a variety of reasons. And it also interferes with people's desire to eat real food. So it has its benefits, but it's also impairing this basic. Oh, like my psychologists ask me, why I'm a psychologist. Why does what my clients eat matter to me as a psychologist? I'm actually putting together this training for the American Psychological Association on everything we're talking about. And my answer is because the very first thing we experience when we are born is love through food, or lack of love through lack of food.
Right.
And so, how we feed ourselves as human beings
Yeah.
is a core self love activity. This is about self care at its most foundational.
Yeah.
And so it absolutely fits into psychotherapy. It absolutely fits into treatment because we're all about enhancing our clients' self awareness, self care, self love. And this has to, it doesn't, but it should begin with how are we feeding ourselves? What is our relationship with food?
Yeah.
Is it, most treatment programs see food as feeding their clients as something we just have to do so they don't die, right? Rather than as a key core therapeutic modality.
Yeah. Yeah.
What you feed your clients and what our clients feed themselves is core therapeutic modality.
Yeah. Yeah, I love this because we wolf down our foods. We don't pay attention to it, right? We're on our screens, right? We have stopped listening to a very beautiful, precise feedback system in our body of, am I satiated?
Mhm.
Am I hungry for food or hungry for love and attention and something
Right.
else? And I'm just feeling one hole with the other, right?
That's right. That's
But
right.
but
And
even if
even
we,
chewing,
yes,
right? None
yeah,
of us
that,
chew enough.
yeah,
I don't chew enough. But chewing is the first signal for the production of hydrochloric acid in the stomach.
yeah, yeah,
Right? If we don't chew enough, we don't get enough hydrochloric acid. If we
yeah,
don't get enough hydrochloric acid, apart from getting heartburn and being put on PPIs,
yeah,
right? We don't get enough bile production. We don't get enough pancreatic acid
yeah.
production. So we're not absorbing the nutrients.
We're not absorbing the nutrients, and exactly right. So there's a method to how different parts of our gastrointestinal system each are playing a very core role. We can't push through that and expect that we're going to have optimal absorption. Nowadays we talk about SIBO for the small intestine, right? And everything is just showing up where it doesn't belong. There's some fascinating things related to chewing right now, for example, in the Alzheimer's and dementia space, which is just like we know about leaky gut, we're learning about leaky brain, the blood-brain barrier, but this wasn't taught in my fellowship, right? That ask your patients who are struggling with dementia or cognitive impairment, what is their dental hygiene? Do they have gums bleeding? Is there cross pollination of what a healthy, normal oral microbiome that we all carry that has become unhealthy?
Mhm.
And now that is seeding, crossing through the blood-brain barrier. And there's evidence-based science that shows this. And
Oh,
now
there is.
you're seeing inflammation in the brain that is accelerating a predisposition. Yes.
Yeah,
we're seeding
it
it.
goes straight up. It goes straight up. And then PPIs make that even worse. So this is actually the first part of my very first lecture in my level 2 training is the mouth.
Uh,
What
yeah,
happens in the mouth and what goes wrong in the mouth.
yeah, that's excellent, right?
Yeah.
This is how the more the patients will, because once we clear all the noise and all the fanciness and stuff, we're going back to basics. We're just going back to elegant bases that have served humans for countless centuries, and we don't have to make it very complicated.
We don't have to. And this is where the beautiful intersection of the lovely high-tech world we live in, where we get to do all of this really sophisticated testing and some of these really sophisticated interventions, it's not either or,
Yes.
right? We
Yeah.
ideally we want to meld them together, and it sounds like this is what you're doing,
Yeah.
is melding them together in a beautiful whole.
Yeah. Yeah. We need to move away from the focus on test-driven functional medicine to more of a trajectory and pathway-driven, right? Let's look at functions. Let's look at systems. Let's understand. And that's where I think it's critical, especially for physician colleagues. Um, in any field where there's advanced training, there's this constant balance of, I know it all, and I'm still an imposter with that healthy imposter syndrome, right? And I tell medical students that having a healthy sense of imposter syndrome should be kept alive, because then that keeps that spark of curiosity versus, I know what I know, don't tell me what I don't know, right? So I think we really have to break down these kind of silos of different disciplines and cross-pollinate this learning from each other. Again, bringing it to the service of our patients.
Absolutely. Absolutely. This is why I run a pretty high level functional nutrition consultation group. And I've got MDs and nurse practitioners and health coaches, right? And I learn so much. And even the health coaches have something to offer the very highly trained professionals. And it's a really wonderful, as you say, cross-pollination group.
Yeah.
So the other thing that, of course, is very close to my heart is amino acid therapy.
Yes.
So how do you integrate amino acid therapy into your program?
So right now we're doing, yeah. So we're at the more diagnostic phase right now. We are starting to look at implementing now some interventions in 2026, because again, we wanted to make sure our foundation is solid first before we just get beyond our skis and stuff. So one of the things that would love to hear from you is, how would you introduce into a program like Enterhealth amino acid therapy, where we have the advantage of these interdisciplinary approaches. We have the advantage of advanced diagnostics, and we have the advantage of patients staying with us for a long period of time. So there's consistency in implementation. There's the acute detox phase. There's more the recovery and resilience phases.
So post-acute withdrawal.
Mm-hmm. Beautiful.
Okay.
Yep.
So what we have found in my work, in my community's work, is that post-acute withdrawal is driven by two things. It's driven by depleted neurotransmitters and depleted and low blood sugar, the reactive hypoglycemia. When the testing that's been done has shown that 95%, i.e. everybody, of people, no matter what process addiction or substances they become addicted to in early recovery, 95% of people test out to have reactive hypoglycemia. So that matters. That's number one. But secondly, it's these depleted neurotransmitters that lead to mood swings, cravings, and stress intolerance. Well, the traditional approach is to use medication just to get people over those humps. Okay. Well, one of the problems with medication is that usually, unless you use the highly addictive things, They take 6 weeks to kick in. Amino acids take 20 minutes to kick in. So if you have somebody in distress in their first week post-acute withdrawal, and how many of our clients are in distress the first week post-acute withdrawal?
Practically all of them.
Right? 100% of them.
Yeah.
They're having trouble sleeping. They're irritable. They're depressed. They're anxious. They're scared. They're whatever. Right? And so we have to give them a lot of TLC to just keep them stable, get them over that hump, get their brains working again. And it takes time. It takes time. And a lot of people bolt. I don't know about your program, but in a lot of programs, people bolt that first week because it's just too uncomfortable.
Too uncomfortable, yeah.
What we have found is that we have a very simple paper pencil assessment tool, but very accurate, actually. We found it to be 80% accurate in clinical practice to assess for neurotransmitter depletion. We bring in and trial the amino acids to identify, because of bioindividuality, one person needs a fingertip, the other person needs 3 grams.
Right.
Right? But you have the staff to do that. You have the organization to make that happen. We trial them to find the right dose it throughout the day. We also make sure everybody has this foundation. And what it does is it turns off these symptoms of post-acute withdrawal within 20 minutes, literally within 20 minutes. And amino acids are anti-addictive. So they are rebuilding neurotransmitter function. And therefore, rather than depleting it, and over time, you get to take less and less to get the same effect rather than more and more. So you start with a high loading dose, until the neurotransmitter system is able to maintain itself, upregulate itself, and maintain that upregulation. Then you can start weaning down on the aminos.
Are you finding the route? Are you finding the route of delivery also as far as being important? Oral, otherwise?
So, look, I worked for 2 different IV amino acid detox programs.
Mm-hmm.
I've seen miracles occur. I believe in IV aminos. And there's so many barriers to IV aminos, but Bridging the Gaps, who's been doing this for about 25, 30 years, they did a study with their people with opioid use disorder. And they compared the people who were just receiving oral amino acids to the IVs. And they discovered that at the 6-week mark, the people who were just receiving orals had the same level of comfort relief that the people who were receiving the IVs. Now, initially, within the first week, the people receiving the IVs felt so much better, so much faster, and got their brains back actually within a week. Okay, people can get their brains back in a week.
Yeah.
And that's like remarkable. So I've seen people walk into one of the clinics I worked with a 0.6, blood alcohol level.
Wow.
And walk out, outpatient program, walk out 7 days later with no cravings, no shaking, no seizure, brain back, and stable mood. 7 days. So that's a miracle, if you ask me.
Yeah, no.
But then they have to continue their work. And the problem is, and Bridging the Gaps found this too, is that with the IV aminos, people felt so much better so fast that they decided that they were cured and didn't need treatment and leave because, well, I'm fine now.
Yes, I'm fixed.
I'm fixed. And then they crawl back 3 months later saying, but I thought I was cured. Why did I relapse?
Right.
And it's like, well, are you going to meetings? No. Are you doing your trauma work? No. Are you taking your supplements?
Yep.
No. Yep. Are you eating protein every 4 hours? No. Well,
yep. So, it has to be all of these cutting edge treatments have to be embedded within a comprehensive program that you cannot just piecemeal and take one versus the other, right?
Nope, you
Yeah,
absolutely cannot.
yeah,
It has to be comprehensive. And the clients, to the best of their ability, have to understand why it matters
yeah, yeah, yeah,
for ongoing compliance.
yeah, yeah. It's moving them through those stages of change of that pre-contemplation to contemplation. And if we can give them more hard data that is science informed, where the risk benefit ratio is skewed to first do no harm, patients will understand that.
Yeah,
Yeah.
yeah,
And then patients will adopt that into their recovery.
they do. They do. And then they share it with their families. And now we're now into prevention, because everything we're talking about are also powerful preventive strategies.
Yeah. Absolutely. There's parallel work that I'm doing in my outpatient practice where my focus is more on dementia and Alzheimer's, where now, for example, with Dr. Bredeson's RECODE program, they're
Mhm.
just publishing some new research about reversal of cognitive impairment, but FDA just approved a new p-tau blood test for Alzheimer's, and it's a marker of the tangles and the plaques in the brain that before we didn't have access to. So
Mhm.
when you're talking about prevention, similarly, any of my patients who are now beyond mild cognitive impairment into early cognitive dementia, major or minor neurodegenerative disease, um, we're wanting their adult children who are 55 or 60 to get that p-tau tested, right? Because genes are not deterministic of an outward expression of what your life is going to look like.
Right.
And there's so many things that even if someone had two alleles of ApoE4 genes, you can still have in a preventative manner a less brittle expression of what those genes mean.
You
So,
sure can. You sure can. Yay for epigenetics.
so that's
Yeah,
where that's music to my ear, which is let's not just help the crisis, but let's start moving this field to more of a preventative aspect.
absolutely.
Yeah.
Absolutely. Well, this has been a delightful conversation. I've enjoyed it tremendously.
Likewise. Now, we're looking forward to more. And I definitely am eager to learn more about the amino acid therapy protocols. And we'll continue with more conversations.
Absolutely. So if people want to contact Enterhealth or you, how might they do so?
So I'd encourage them to, and I think if I'll email you some links in your show
Yeah,
notes.
we'll put this in our show notes.
The Enterhealth website, I think, is a really good enterhealth.com. They actually have a treatment redefined podcast. Looking forward, Christina, for you to coming there and teaching us, more of your work
Exactly.
and how we can help our patients. That's the website, Enterhealth. I have my private practice, the Noasis Clinic, that is more focused on dementia, Alzheimer's, early detection, early intervention, and then my Psychiatry 3.0 blog that I would encourage people to sign up for.
Wonderful. We'll have all of that in the show notes. So thank all of you for being with us today. If you enjoyed this episode, please push the like button and the subscribe button and share this with everybody you know. And we will see you next time. And Dr. Latif, thank you so much for being with us today.
It was my pleasure. Thank you for having me on.
Thank you for tuning in to Power Up Recovery with Nutrition. I'm Christina Veselak, your host, and I hope today's episode has inspired and equipped you with new insights and tools to support your recovery journey or practice. If you enjoyed this episode, please subscribe, leave a review, and share it with others who could benefit from the knowledge shared here. Stay connected with us for more episodes filled with practical advice, expert wisdom, and inspiring recovery stories. Remember, nutrition is a powerful tool in mental health and relapse prevention. Power up your recovery today. I'm Christina Veselak, and I'll see you next time.